Hello everybody, welcome to my YouTube channel. My name is Iriarte, and I'm going to show you the nerves of the upper limb. We started with the median nerve and now it's the turn of the cubital nerve. And let's go. As you know, the brachial plexus is formed of 5 roots from C5 to T1, and the cubital nerve has innervation from the C8 and T1 roots. These 2 roots form the medial cord, and this medial cord forms the cubital nerve. If we follow this nerve distally, we will notice that how at the axilla it will be located posterior to the axillary artery. If we remember, the median nerve was superficial to this axillary artery, and the cubital nerve will be posterior. This is the cubital nerve, and it will be the medial nerve. At the arm, he goes medial, very superficial, stuck to the medial head of the triceps, as you can notice here. Anterior with the brachial artery will be the medial nerve, and posterior the cubital nerve in the medial side of the arm. Where we are reaching its distal third, the cubital nerve crosses the stratus arcade. And this is a very important thing to know. Which is the stratus arcade? If you remember, we talked about the stratus ligament when we saw the median nerve. You remember this medial osteophyte in the distal humerus, which sometimes has a ligament between this osteophyte and the medial epicondyle. This was the ligament of Strathers, and this ligament was related with the median nerve, which passed underneath this structure. But now we are talking about the arcade of Strathers, and the arcade of Strathers is some fiber, some connective tissue which joins the medial head of the triceps and the medial intermuscular septum, and the cubital nerve goes underneath this connective tissue. So remember, the Strathers ligament is related with the median nerve, and the Strathers arcade is related with the cubital nerve. Okay? This is a potential area of conflict here, so it's important to know. When we are going, when we are going distal, the cubital nerve passes from its anterior position related to the intermuscular septum. It perforates this septum and goes posterior, close to the elbow. And in the elbow, it will be located posterior to the medial epicondyle. No branches are located in the arm of this nerve. What about ultrasound? If you remember the median nerve, we started always with this cut here, this axial plane in the middle of the upper arm, at the elbow, just here. So this will be the same cut we are going to use for locate the cubital nerve and study this nerve. It's very important to notice some bony contours. First of all, the medial epicondyle here, very easy to see, and the olecranon. You can palpate with your fingers and place a probe over these 2 bony structures. Use a good amount of gel because the patient will be uncomfortable if you don't, okay? And place a probe over these structures. I usually ask the patient to lay on this side because it's for me easier to perform a comprehensive scan of all the nerve, and usually it's enough with this position. If we need some specificity at the axillary area or dynamic maneuvers of the elbow, we must change the position, but for a good initial evaluation, this position is good for me. Okay, and we start at the cubital tunnel between the medial epicondyle and the olecranon. The nerve will be located here, very close to the medial epicondyle, and usually as a dark oval shaped area here. If you don't have a good view or you are not sure, just go slightly distal or slightly proximal, and the nerve becomes very superficial and very easy to see. but this is the first scan I recommend always to begin the evaluation of the ultrasound of the cubital nerve. Once we have located this area, we go proximal, and the nerve becomes easy to see, more posterior, in the medial side of the triceps muscle. This is the triceps muscle, this is the medial head, and this is the cubital nerve. In this drawing, this is wrong. This is not an artery, this is a vein, so its color should be blue. And this is the medial intermuscular septum here. So here the cubital nerve is posterior to this septum. If we continue distal, we will notice how the nerve perforates this septum and is located anterior to the septum, close to the brachial artery here. This will be the median nerve, and this posterior is the cubital nerve. Now we are going to check all these movements of the cubital nerve with a video. We will start at the cubital tunnel here. We locate the medial epicondyle and the olecranon. And we go proximal. And very soon the nerve becomes superficial. We are still here. Okay, superficial and medial to the medial head of the triceps. If we continue, this is the septum. We'll notice the nerve going through the septum and locating here anterior to the septum. And again, here we can see the brachial artery with the median nerve, and we will see how the cubital nerve goes very close to the nerve, but in the posterior position here. So this superficial nerve will be the median nerve, and this posterior nerve will be the cubital nerve. And here we are at the axilla. And again, this is the axillary artery now. This is the median nerve, and this is the cubital nerve, posterior. Okay. And now we are reaching the cubital tunnel, and the nerve crosses this tunnel. And this is a very important structure, the cubital tunnel, because almost it's very frequent to find problems with the nerve at this area. It's the second more common entrapment neuropathy of a nerve in the upper limb. The first is the carpal tunnel syndrome, and this is the second, the cubital tunnel syndrome. So it's very important to know its anatomy. Which boundaries has this tunnel? First of all, the bones. Medially, the medial epicondyle, and laterally, the olecranon. The floor is formed of the joint capsule of the elbow and the posterior and transverse fascicles of the medial collateral ligament. As you can see here, this is the posterior, this is the transverse ligament of the medial collateral ligament of the elbow. And the roof is complicated. And there are several different authors that call the different structures in a different manner. So it's difficult to find a unique form to describe these structures. I will talk about the first one, most common, which is that between the medial epicondyle and the olecranon, this is the retinaculum at this level. And the cubital nerve passes underneath this structure, this retinaculum, at the entry of the cubital tunnel. Then the cubital nerve will be under the two heads of the flexor carpi ulnaris. The flexor carpi ulnaris is a muscle with a close relationship with the cubital nerve and has two heads. One head inserts in the medial epicondyle and the other in the olecranon. And the cubital nerve passes between these two heads. But these two heads are joined with a connective structure which some people call the arcuate ligament or the Osborne ligament. So this should be the retinaculum, and this should be the arcuate or Osborne ligament. Other people call this the ligament of Osborne, and this the arcade of Osborne. So different names should be found if you look into different papers, so it's difficult to be sure what are we talking about. But in the real patient, these two structures are not different. This is a continuum between the retinaculum or the arcuate ligament and this structure, this fibrillar structure here. This is a continuum, so there are no two separated structures. Okay. Again, we can use this position to assess the cubital tunnel, but you can use also this position, very easy to perform and very easy to check this area. But I usually use this position because it's more easy to follow the nerve distally. In this position here we are very good, but it's not very easy to follow the nerve distally, and I prefer to check all the nerve in one maneuver if I can. I use the fingers, I place the probe over the bony contours, and I search these structures. So this is the first cut we must find with the nerve just located here. And you can notice this small structure here, which will be the retinaculum. And if we move the probe slightly, we will notice the beginning of the two heads of the flexor carpi ulnaris, and this structure here between the two heads, which continues with the retinaculum, called the arcuate ligament or the Osborne ligament, and the nerve located between the two heads of the muscle. Slightly distal, here we will have a better view of the muscle, of the two heads of the muscle, the nerve below two heads, between the two heads, and again this structure here, this connective structure here, joining both heads, and called the arcuate ligament or Osborne ligament. Okay, once the cubital nerve has left the cubital tunnel, it goes through the forearm, and it continues between both heads of the flexor carpi ulnaris. As we go distal, we will notice how the nerve will be located below this muscle, here, and between two muscles, the flexor digitorum superficialis and the flexor digitorum profundus. If you remember the medial nerve, if we continue deeper between these two muscles, we will find the medial nerve in the other side of the forearm. Okay? At this level, it releases branches to the flexor carpi ulnaris and the medial half, the medial cubital half of the flexor digitorum profundus, the components of the fourth and fifth fingers. As we go distal, we will notice how the cubital artery will be more closer, and will join the cubital nerve in the medial area, in the medial third of the forearm. At the distal forearm, it releases two more branches, two sensory branches. One is very difficult to find, which is the palmar cutaneous branch. Usually is more proximal than the dorsal cutaneous branch, and it innervates the hypotenar area, cubital area of the hand. And the second is the dorsal cutaneous branch, which becomes posterior and will innervate the dorsal aspect of the hand. Okay? And if we perform the ultrasound scan at this medial half of the forearm, we will search this muscle with this oval shape, which will be the flexor carpi ulnaris, and below this muscle the cubital nerve will be here with the cubital artery. Also notice how this nerve will be between the flexor digitorum superficialis and flexor digitorum profundus, and the medial nerve, if we continue displaying between these two muscles, will be located here. So if we continue here, this is the medial nerve. Okay. And if we go distal, in this case we have found the dorsal cutaneous branch of the cubital nerve, usually a big branch, which is located here. This is the quadratus pronator quadratus muscle, and this branch will be between this muscle and the flexor carpi ulnaris and goes posterior, passing through these two muscles. This is the cubital artery, this is the cubital nerve, and this is the dorsal cutaneous branch of the cubital nerve. At the wrist, it goes into the Guyon tunnel. But what is exactly the Guyon tunnel? This is another possibility, another location which is very possible, it's quite possible to find problems with the cubital nerve. And these are the boundaries: proximal and medially the pisiform bone. Laterally, the hook of the amate bone. The floor is the transverse carpal ligament, and the roof is the palmar carpal ligament. And a palmaris brevis also contributes to the roof of this Guyon's tunnel. It contains the cubital nerve and the cubital artery here. Once past the tunnel, the nerve releases several branches, and these branches, the first branch it releases is the deep motor branch here, and this branch, as its name indicates, is deep, so very close to the hook of the amate here. This branch is the first released and will innervate the muscles of the hand. And a superficial branch continues and divides into several branches, which will innervate this area of the cubital half of the fourth finger and the fifth finger. Okay, so if we can find affection of both sensory and motor components of the cubital, so this is indicating that the problem will be here. Only motor, which usually indicates the problem is very close to the hook of the amate, and only sensorial problems or sensory problems, which indicate that the injury is distal to the motor branch. Okay, we place the probe here. We will find the pisiform here. This is the cubital artery, and medially the cubital nerve. This is the transverse carpal ligament, and this is the palmar transverse ligament. This is the palmaris brevis muscle. As we go distal, here, this is the hook of the amate. This is the cubital artery, and we will notice the nerve dividing in several branches. Usually this branch here is the deep motor branch, very close to the amate, and these are sensory branches. This is a branch or a sensory branch in its long axis, and in this video we will notice all these branches. The deep branch is very difficult to see because it goes down and becomes dark because of anisotropy, and is difficult to see, so be very careful. And here you can see the deep branch very close to the amate, or the hook of the amate here. This is a deep branch going deep to the muscles of the hand, and these are the sensory branches, superficial of the nerve, and we can follow all the branches till the tip of the finger. As we saw with the median, a rule is that all the intrinsic muscles of the hand are belong to the cubital nerve, except the tenar eminence, which belongs to the median nerve. All the tenar eminence belongs to the median nerve, except with exception of the deep head of the flexor pollicis brevis, which belongs to the cubital nerve. And the only exception are the lumbricals, and first and second lumbrical belong to the median nerve, and third and fourth belong to the cubital nerve. So you can remember all the muscles of the hand and its sensory and its innervation with this rule. And what about sensory innervation? The fifth and fourth and half-fourth fingers belong to the cubital nerve, and the rest of the fingers belong to the medial nerve, except the dorsal area, which will belong to the radial nerve, but we are going to see that on next video. Okay, and that was all. I know there are too many things to remember, but it's very useful, the ultrasound, to scan all these nerves, and very useful in our daily practice. So try to find yourself all these branches and be very patient. Okay, I hope you enjoyed the video. If you like the video, just check the like, and don't forget to subscribe if you want more videos. Thank you very much.